It's Dr. Centeno, and thanks for joining me this morning. Got an interesting topic as usual. Today we'll be talking about the differences between upper cervical alignment or misalignment and instability. Now, this is a common one or a common misconception I see, and that and that is that patients often confuse being out of alignment with being unstable. And I want to talk today about how there's a little bit of overlap there, but for the most part, they're two very different concepts. And as usual, we'll go through maybe 10 minutes of didactic lecture on this topic. Then you can ask questions about this topic or really any topic at all. If you want to ask questions, it's best to do that early because almost always what happens is that I get so many questions as I go along that I can't get to those questions by the end of the hour. So best thing to do is to get your question in as early as possible. If you can just go ahead and put your question in the comment section, whether you're on YouTube or on Facebook, that's generally how this works. But try to get those in early, because if we don't get those in early, it gets very, very hard for me to get to all of those questions by the end of the 1 hour live. So again, today we're going to be talking about the differences between upper cervical alignment versus instability and how there's a little bit of overlap between those two concepts, but that they're really quite different. And then again, we'll go through the same Q&A. So if you want to get your question answered, just put it in the comment, whether you're on YouTube or Facebook, and then I'll see that on my end. I'll highlight the comment, answer the question. Realize that again, almost always there are more questions that I can get to. So try to get your question in early, otherwise I may not get to it by the end of the 1 hour live. So let's go into this topic, right? Because this is an interesting one. I see patients all the time confusing these concepts, and I can see why they do, because there's a little bit of overlap between the two, but they're very different ideas. So again, it's a common question I get, where many patients confuse their alignment or misalignment with being stable or unstable. So what is misalignment? Misalignment means, from a chiropractic or an upper cervical chiropractic sense, in the resting neutral state, the bones are not straight and perfectly aligned. Now, lots of things can cause misalignment, right? You can have a side bend in your spine, otherwise known as scoliosis. Now, that scoliosis can be structural because that's the way the structure has developed as the patient grew, or it can be degenerative, meaning as time goes on, someone gets more scoliotic because that's the way their spine degenerated, or even proprioceptive because there's bad position sense coming in from up here because of an upper neck injury. There's a side bend or a little bit of scoliosis. You can also see misalignment due to stabilizing muscle atrophy. So when those upper neck muscle stabilizers go offline, you can also see that on MRI. You can also do the same thing when you have muscle imbalance, right? I see many times on MRI where you see the right upper cervical stabilizer, let's say the obliquus capitis inferior is bigger than the left. So that could cause things to be misaligned. You can see fascial asymmetries. You can have a fascial injury on one side, and that is allowing one vertebra to turn a little more. And again, you can see instability that would allow misalignment. Now, instability is a different concept, right? Instability is a movement-based concept. When the patient moves, the movement is beyond the normal limits of the range of motion. So for example, if you look at my my finger joints here, right? My finger joints have a certain range of motion. Let's look at this old man finger joint here. It can go this far this way, but then it stops. It's being stopped by the ligaments. And it can go this far that way, but then it stops and it's being stopped by the ligaments. But if it were to go beyond that range, then it would be unstable. So what can cause craniocervical instability, ligament laxity, or stabilizing muscles that atrophy? So getting a little deeper into misaligned, again, it's really pretty simple. One vertebra simply isn't straight on another. So it's a small misalignment that can cause nerve irritation, that can cause bad position sense information in the upper neck to come in from those upper neck facet joints, etc. Now, instability, let's dive deeper into that concept. These are actually diagrams by one of my favorite scientists of all time, biomechanist Panjabi from Yale. And pretty simple concept here. You've got range of motion on this axis, on the x-axis. On the y-axis, you have force. So Panjabi started this concept that there was muscular stability, which is this mid-range here, right? You get a little bit of range of motion in the middle. So again, if we're going to look at my finger, my muscles control the range of motion when the stability is in the middle part of that range of motion. And you don't have a lot of resistance to force going on there. Hence, you have this kind of cup-like shape. Now, here we see something a little bit different. Here we start to climb the wall, if you will. So as we get towards the end of the range of motion, again, with my finger, as we get towards the end of the range of motion, my finger stops. There's resistance to any additional motion. And that end range joint stability is controlled by the ligament. So at some point you hit the ligament, and that ligament doesn't allow it to go any further, and it starts to push back. That's normal. That's what ligaments do. So in craniocervical instability, you get to that end of range of motion, but then it continues to move and don't have that resistance at the end range. Now, if you have ligament instability, our cup turns into something like this, right? Eventually, if my ligaments weren't working here, I'd be able to push that joint further and it would continue to move. So that resistance to movement would collapse and it would look something like this that you see here. Now, there is a little bit of overlap between these two, right? You can be misaligned but stable, and you can be unstable but perfectly aligned when you're just walking around. In fact, you don't get out of alignment until such time as you start to move. But you can be misaligned and unstable. So misaligned is a concept of position at rest. Unstable is a concept of moving beyond the normal range when you're going through that range of motion. So misalignment and instability are different things. You can be misaligned and stable. You can be unstable and have very little misalignment at rest or perfectly aligned. But you can be both misaligned and unstable, but they're not interchangeable concepts like I see them used online. So that's the reason why I wanted to have this little discussion about what these things actually were. I think that's it. So I'll start taking some questions, pretty short one today. Let me get that off of there. We'll go to a different setup and I'll start taking some questions. What pain medication usually works for CCI? In my current condition, I won't be able to make it to the US. Any medication or anything else you can recommend to help me through the trip? What What pain medication? Well, pain medication is to help control pain, right? So if you have a lot of pain with craniocervical instability, there isn't a specific medication that's going to work better or not for craniocervical instability patients. Routine narcotic pain medications can work, but they're addictive. Then you get into the newer pain medications. We've been using some Gervanax, for example. That's a relatively new one this last year. It's a non-opioid pain medication. There are other kind of quasi-opioid pain medications like tramadol, otherwise known as Ultram here in the United States. A lot of patients take a lot of non-steroidal anti-inflammatory drugs, Motrin, Aleve, etc. But again, those have the problem of blunting the inflammatory healing response, so those can lead to more chronic pain. And then we've got other medications like muscle relaxers, etc. So there really isn't a single medication that most CCI patients are responsive to. One pain medication that might work well if you've got a lot of pain is Lyrica or pregabalin. That one can help sort of turn down the pain knob on the sensitivity in the nervous system, and it tends not to be addictive or cause other problems like the other ones. So those are just things to consider, but there really isn't a single pain medication. I wish there was. Do you have many patients who vomit when they have pain? Being nauseated and vomiting is something we see in some patients, maybe 5 to 10%, that have chronic pain. Now, being nauseated and vomiting with CCI can be a separate set of issues, right? That can be due to balance, position sense issues, a little bit like being on a boat. Where we have mismatches between the information coming in from the position sensors in the upper cervical spine versus the information that's coming in from the inner ear or from the eyes. So being nauseated, as in many CCI patients, is more linked to balance issues or being dizzy, vertigo. But there are some patients that just get nauseated when they have pain as well. Just an FYI, YouTube is showing in the shorts format. Yeah, it seems to be outputting two different things here. Let me see if I can change that. Yeah, I don't know what's going on there. Apologize if that's showing up weird on YouTube. I'll try to stay in the center here so you guys can see me. I'll also put my vertical up so I can make sure that I stay in the right place for you guys. Dr. C, VTOS, and degenerative disc disease, maybe, C56 instability, also hypermobile. Sending you my info to your assistant. I'm in Atlanta. I would love to see you in person for a clinical exam. Could you be my physician? Yeah, so as far as my practice goes, since I'm only in the office 2 days a week now, my focus is on the PICL procedure and craniocervical instability. It is not on anything else. So if you have the type of craniocervical instability that needs an PICL procedure, then by all means, I can certainly be your physician. If you don't, that would be a different physician within the practice. So that's kind of how my practice has evolved over the years. Aaron, can positive autoimmunity going into the PICL interfere with the healing process? Well, autoimmunity is a pretty broad spectrum concept or topic, but can autoimmunity interfere with healing? It theoretically can. Having said that, I would say about 1 in 5 of our patients probably has some sort of autoimmune diagnosis, not really rheumatoid arthritis, but other types of autoimmune diagnoses. And if you include things like MCAS, it would get into probably 1 in 3. So I don't really see that those two things are related in the patients that I see every day, that patients that carry some sort of immune diagnosis are responding more poorly. Submitted advance by Sherry. Is it possible to have both? I think she's talking about misalignment and instability. It is. There is some crossover there, but the two concepts, really what I wanted to bring up, are not interchangeable. Taylor, how often do you see memory issues in CCI patients? You know, we see a lot of brain fog in CCI patients, and within that spectrum of brain fog, we certainly have patients that have short-term memory issues. Can't remember what I just did or said, or, you know, did I take that pill or not take that pill, that kind of stuff. So that usually fits within brain fog, which is a pretty common CCI diagnosis. About 1 in 3 of our CCI patients report brain fog. Vera, hi, Dr. C. What are the pros and cons of getting a second PICL at 4 versus 8 months after the first? Generally, how and when can one know if a second one is needed? Yeah, so the reason why we look at around 3 months is that for most patients, about 70 to 80% of the relief that they're going to get, they'll get by that 3-month mark. Now, for example, so let's say after the first procedure, you got 30%. Well, it's very unlikely you're going to get anywhere close to 100% if you wait. So we would pull the trigger on a second procedure at that point if you got 30% relief from the first. But let's say, on the other hand, you're one of those more rare patients that got 80% relief at 3 or 4 months, then you might want to wait to see if you can not need a second procedure. So a lot really depends on the magnitude of the response from that first one. If it's the average magnitude of response, then almost always you're going to need a second. There's really no advantage or disadvantage to wait 4 or 8 months, meaning there's no big advantage to wait the additional 4 months. But if you had a very large response to the first one, then you may want to wait to see if you will even need a second one. Undercover Sentinel, how do you define the plan of action for vascular TOS? What diagnostic imaging do you need? My DMX is showing no CCI, with instability at C5-6. I have awful dysautonomia, VTOS, inflammation, edema in the arm. Well, so getting off the CCI concept here, I don't differentiate vascular from non-vascular TOS because the nerves and the vessels run in the same bundle. So it's 6 of one, half dozen the other, as my father used to say. As far as for TOS, TOS is a common problem in patients that have chronic cervical issues. And usually the first thing you do is to treat that cervical issue. So if someone had some instability at 5-6 and nerve irritation there, we might start with a platelet-based degenerative disc disease procedure, tighten down those ligaments, inject platelet growth factors around that exiting spinal nerve. Having said that, they would also be in physical therapy to work on opening up some of those common areas for TOS around the scalenes, pec, etc. And if that didn't work, you could also get direct hydrodissection of either of those areas under ultrasound guidance in combination with treating the lower neck. Vera, what is SCP, PLM, PIM? I'm not quite sure what PIM is, but SEP is basically our way to say leukocyte poor, high dose, platelet rich plasma. PLM is our way to say a high dose platelet lysate. And I don't know what PIM is. Maybe that's a typo. I don't know. And purple hydroxy, how does PRP help arthritis? It's interesting. We have a good amount of data at this point through multiple randomized controlled trials that in large joints, where we can easily image those joints in high detail, like the knee, for example, that more likely than not, platelet-rich plasma, high-dose platelet-rich plasma, is a what we call a disease-modifying osteoarthritis drug. So what that means is we've got evidence that either reduces the advancement of osteoarthritis or can reverse osteoarthritis. Now, on the reversal side, I think that one remains to be seen a little more. But on the delaying side, that one seems to be fairly well sourced with scientific references right now. So high dose PRP seems to be, based on the current literature, a disease modifying osteoarthritis drug. How does that work? It works in all likelihood, although no one's 100% sure, through the growth factors that are in PRP, things like, for example, transforming growth factor beta, vascular endothelial growth factor. It may work through some of the exosomes that are within PRP. So it's probably a growth factor play that's making that work. Undercover Sentinel, do you have a recommendation for a mid-age woman HRT practice or doctor that is best in class to balance hormones? I can tell you that my wife goes through the Centeno-Schultz program. Centeno-Schultz is a national one. I think it's CENE Genics, GENICS. That's a national group practice that does very high quality hormone replacement therapy. As I've said before, for women, HRT is not going to your OBGYN and having them give you estrogen. It's not a set and forget. It's a combination of estrogen, progesterone, and testosterone for women. And then all of that is followed very, very closely with blood tests multiple times a year because it needs to be constantly dialed in. It's also generally not pellets either, because those are much harder to dial in. So for women, it will be injections, it'll be creams, it'll be oral. But my wife goes to Centeno-Schultz, if that helps. Nathan, what training or expertise should I look for if I want to try to rehab with an in-person physical therapist? I found a few that know what CCI is, but I'm trying to narrow it down. You know, Nathan, I often recommend IPA physical therapy, like the beer IPA. If you go and just look up IPA physical therapy, you'll see a national provider list. I like those guys because they are, they understand what craniocervical instability is. They know how to test for it. They understand how to rehab it. And they are a very training focused group. Meaning that they've got levels of training and fellowships and other things to make sure that the therapists that have gone through their programs are highly, highly educated and can meet a certain standard. So that's the national group that I like. Taylor, can CCI cause scoliosis? If it does, will fixing CCI cause the spine to correct itself? I don't know that we know that CCI can cause structural scoliosis. So I think we have to break this down, if you're younger, into two different categories, right? One is structural, and that's where we start to see changes in shape of the bones. That's usually not at all CCI related. That type of scoliosis is usually a combination of genetic and postural. So basically, what we believe is that it takes a genetic predisposition, and this is a study that came out maybe about 2 years ago, plus a lot of looking like this at your phone. And if you add those two things together, so basically bad posture, which is common in teens because of the phone phenomenon, and the right genetics, you end up getting a side bending and scoliosis. Now, there may be many other genetic factors and or other types of factors that have yet to be discovered. Now, when it comes to proprioceptive scoliosis, and that is a little tiny side bend related to the fact that your upper cervical spine position sensors don't know which end is up, that's a little different. And in that particular situation, that can be corrected if you correct the upper cervical spine input. Casein, our GLP-1 meds and the many peptides people are taking now helping or detracting from regeneration techniques that you do. Well, I want to put GLP-1s in a different category, right? The GLP-1s are well studied now. And we have lots and lots of human data, and we've got pretty good data that they can reverse metabolic syndrome. Metabolic syndrome is when you gain weight, get high triglycerides, high blood pressure, etc. And we know that that's not good for healing, metabolic syndrome. So the GLP-1s, I would say, would help healing, all things being equal, trying to take a best guess because we don't really have that kind of research. When it comes to other peptides, that's a totally different story now. Now we're talking about stuff where we have no human clinical data. So, for example, a common one is BPC 157. We don't have any human clinical data at all for any of those types of peptides. And so it's anyone's guess as to whether or not they help humans. There's a little bit of in vitro research, and there's no quality control on any of that. So your guess is as good as mine whether or not those help healing. I always tell patients, I don't think they're probably not going to hurt, but I've got no idea if they help. But GLP-1s would be a completely different phenomenon. M-Purple, what kind of symptoms could be indicative of a damaged AO ligament? Really, it's just going to, that's a 0-1 ligament, so it's going to be a type 1 instability. If you look at what the AO ligament does, that's the ligament that's going from the atlas up to the skull. So you're going to see some rotational component to that and some side bending component to that, but very much focused at C0, C1. Phyllis, if a patient has EDS and confirmed CCI per upright MRI, what are the chances that Dr. Rosa will be able to help versus your clinic? Well, Dr. Rosa does very precise upper cervical adjustments, really one of the best in the world at that, based on his analysis of upright MRI. That's conservative care, right? So every CCI patient should try to see an upper cervical chiropractor or go through conservative care before ever considering something like an EPICL procedure or even advanced posterior injections. So I think what you're bringing up is conservative care should always be tried and failed before injection therapy is pursued. Now, there might be reasons why you can't do the conservative care. For example, we have patients that try one visit of physical therapy and it flares them up in a huge way. So there may be reasons why you can't really go down those routes, but in general, that's the way it goes. What would you treat? Would you treat a patient that had a DVT due to vascular TOS? I haven't, but that's my biggest fear. Vascular TOS doctors push for the trifecta if DVT. Listen, in my medical practice, and I'm getting to be an old guy now, let's see, how long have I practicing medicine. I got to do the math. 23 years since no, 33 years since I left residency, and then a whole bunch more, obviously before that. So 40 years. In 40 years of practicing medicine, I haven't seen more than 1 or 2 patients with an upper extremity DVT that was linked to vascular TOS. And in fact, in the kind of TOS patients we see day in, day out, I've never seen one at all. So that's the best I can tell you there. I don't know your specific clinical matrix to advise you about that, but I can say that those sorts of things are incredibly rare. Nathan, do people with type 1C benefit from particular type, or maybe, okay, sorry about that, Nathan, I got to reread this. Do people with type 1 benefit from a particular type of rehabilitation or treatment alongside their PICL journey to ensure the skull can position itself in the joint better? I think what you're asking is, do you need a specific type of rehab or other type of conservative care along with a PICL? So again, patients are going to fall into different categories here. The first would be a patient that does really well with upper cervical chiropractic. In that kind of patient, we'd want them to continue upper cervical chiropractic. Having said that, we do not want patients to start upper cervical chiropractic after PICL if they haven't done it before. Then when it comes to active rehab, we have a number of different programs there. We've got the online eye exercises. We're now working with neck care on a rehab program that we'll start trying in a few patients going forward here. That's the proprioceptive testing system that we use in the office to look for upper cervical issues. And we've got the program created by Todd Ball through his postural physical therapy program. So those are 3 different types of rehab that we will use. A really good one, I think, is getting with Todd Ball for prehab and then doing that for rehab after the procedure. I saw your YouTube short about some needing that second PICL to get any results. Will you reject a patient who's not gotten a positive response to 2 PICLs? Would a third always be a waste of time? You know, this is an interesting journey, right? Up until about 2 or 3 years ago, I wouldn't let a patient who didn't get a response from the first PICL to proceed to a second. Maybe it was 3 years ago, something like that. Then I had 1 or 2 patients, maybe 3 or 4, who eventually talked me into it, and we started to see some results. So that floodgate opened a little bit, and we started to see some results. And about 60% of the patients who didn't get a response from the first got a response to the second. Now, I don't have any or that many, maybe there's 1 or 2 rare patients that I can recall that I've allowed to go to a third if they didn't get a response from the first 2. Could it be that we're missing something there? That could be. That there might be some percentage of patients that respond to a third. I just don't know. So, you know, that's the history so far. And we've tried to be very cautious as we've gone along, especially when the procedure was newer, not to let people move forward who didn't respond to a first to a second. And then eventually we did. We found out that there could be some value there. I really don't know what happens to someone who hasn't done well with 2 and we let go to a third. Got diagnosed from 1 specialist with CCI AAI, but others in PT who deal with instability say it's not. I deal with a lot of anxiety, memory issues, difficulty recalling memories, what to do. Yeah, I really can't advise you with that kind of info, so I'm not quite sure what you should do in particular. Again, always happy to look at images, do a pre-screen to try to see if the CCI meets our criteria. Our criteria tend to be tougher than the criteria used by most surgeons. So that'd be the best thing I could tell you to do, is to try to see if you meet our criteria for craniocervical instability. Hey guys, do me a favor. Like, comment, share, subscribe. If you want to pay it forward in the CCI community, one of the best ways to do that is to like, comment, share, subscribe. You're commenting, obviously, by asking the questions. So do me a favor and give me a like here, just because we want other CCI patients to know that this kind of thing happens, right? The good news is we're seeing more and more patients join us on Sunday mornings, which means better questions for all and better answers for all of us to learn. Having said that, we want to make sure that the average CCI patient who's kind of lost in the wilderness gets to find this kind of content, and that's regrettably how it works. Undercover Sentinel, what testing do you need to determine the health of 5-6 ligament damage and DMX? You know, the damage is interior or posterior. How do you inject if anterior? So in general, on a DMX, in flexion and extension, if you've got backwards movement of 5-on-6 and extension, that's going to be the anterior and longitudinal ligament. So that's an anterior disc axis type approach. That's a highly advanced injection. If it's posterior ligament damage, then you're going to see forward movement on 5-on-6 in flexion, and that's more of a simple ligament injection from the back. Now, if there's nerve irritation at that 5-6 level, you also need to treat the nerve at that level. Oftentimes at 5-6, that can be done with a facet overfill and using platelet growth factors. There are Regenetics practitioners in the US, but no one like you able to see the big picture for V2S, what to do. Yeah, well, all of the doctors in my clinic were trained by me. In order to work at our clinic, you have to have gone through our fellowship, meaning there's no one that has ever worked at our clinic that did not go through our fellowship. So that means they were all personally trained by myself and Dr. Schultz. So that would be my recommendation there. Let's see here. Lori, what is the best way to see ligament laxity, maybe on imaging? Yeah, so number one, it has to be movement-based imaging, right? In order to see if a ligament is working or not, we need to have a movement component. So what does that mean? There's really only a couple kinds of movement-based imaging for the neck, for example. So one would be well done flexion extension x-rays. Now that's going to show just certain types of CCI, mostly a type 3 at C2-3. And also you can see a type 2A of the transverse ligament. So that's one thing to do. When I say well done flexion extension MRIs, or I'm sorry, flexion extension x-rays, you really need to crank it into flexion and crank it into extension for that to be a valid study. And oftentimes the rad techs get in trouble if they hurt a patient. And so they get into this mode of not asking the patient to move enough, which is really not good if we're trying to see instability. Then the next type of imaging would be digital motion x-ray. That's kind of like a flexion extension x-ray, but we also add in other types of moves, and we add in actual movement where we can see things that are positioning themselves against each other during that movement. So the vertebra doing their thing. So it's kind of like an x-ray movie. And there we usually add in that AP open mouth view lateral bending that can get us into the type 2B craniocervical instability. And then finally, you've got upright MRI with flexion and extension. You still need to crank it into flexion and crank it into extension. And that allows us to really dig into the type 1 instabilities, those instabilities that are between the skull and the upper neck. So hopefully that answers that question. Greg, getting EPICL third week of April, is it best to work on alignment after procedure and some healing has occurred? Yeah, Greg, so if you have, as I always say, a well-established relationship with an upper cervical chiropractor prior to all of this, and it's always giving you temporary relief, by all means, we would encourage you going and getting additional upper cervical chiropractic to stay in alignment. If you've not had that kind of relationship, we don't recommend adding it in. Undercover sentinel, would it be possible that DMX shows no CCI and upright MRI shows it? Yes, that is possible. So again, upright MRI tends to show type 1 instabilities really well. A DMX tends to show type 2 and type 3 instabilities really well. Casein, when do symptoms occur with respect to misalignment and or instability? Well, that's a pretty complex question to answer, but in general, what we're talking about is that nerves and joints can get irritated really in both types of things. So it's kind of the same. The only difference is with instability, we tend to see much more nerve irritation / damage or joint irritation / damage because we have things moving beyond their designed limits, and that's going to cause more trauma. JS, can scoliosis be fixed? What symptoms does it cause? Scoliosis can certainly be managed with regenerative medicine. I've done that for years. What symptoms does it cause? Scoliosis is a side bend. So on the side of compression on the facet joints, for example, which is going to be the concave side of the bend, you're going to get facet pain at the apex there. On the other side, you're going to get stretch. So on the convexity of the curve, you're going to get stretched out tendons, for example, that are going to be pissed off and need to be treated. So basically, on the side of the concavities, you've got usually nerve irritation, facet joint arthritis. On the sides of the convexities, on the side of the convexity, you normally see things under stretch, and that stretch is normally presenting itself as tendon type pain or tendinopathy. So on that side, tendons tend to need to be treated. Sandra, do we need to be in perfect alignment for Prolo, PRP, or PICL? What's the best way to get in alignment with CCI? You don't need it, nor do we require it. But again, we always try to make sure that our CCI patients try upper cervical chiropractic, number one, to see if it just solves the issue. Maybe it's not really so much CCI as just poor alignment, and then they don't need to see us. Maybe they do that in rehab. And then if they get temporary relief with that, then they can obviously continue to play right through as we treat them. E.E. Smith, do you believe that AI will soon have an impact on medical research? Yeah, I think that we're going to see more changes due to AI in the next 20 years than we've seen in the last 200. And that's going to affect all aspects of society, including medicine. So in medicine, we will see AIs that are smarter than any doctor. We will see eventually robotic surgeons that are better than any surgeon. We will see medical research change, right? Right now, if you look at it, medical research is mostly based in universities. Every once in a while, you'll see a guy like me who chose not to go the university route, but still does medical research. And I think that's going to change because at the end of the day, universities have been places where expertise lives, and expertise will now live in a box. So it will not live at a university. So your average phone 10 years from now will probably be smarter than all of the university professors that are currently living. So there's going to be some massive changes. The good news is we're going to see lots and lots of medical innovation very, very quickly. And the good news is we're going to see that hopefully translate to patients, although we may need to redesign our regulatory system here in the US, because our regulatory system here in the US is pretty antiquated when it comes to trying to get new things to patients. So, so hopefully we adapt. If we don't, we'll see good changes, but they'll be slow. If we do, we'll see rapid changes. But yes, AI is about to change everything, including medicine. It's been advanced by Harry Winston. Without treatment, would you expect CCI to get worse over time? Yeah, I get this question quite a bit. And I would say that in general, yes, that's what I see. So if I take all people who I see and who don't get treatment, meaning that obviously I've got a cohort of patients who I saw for maybe a telemedicine that, just periodically send me an email every once in a while. Oh, I probably have at least 100 of those, or maybe several hundred through the years. And maybe they couldn't move forward because of finances. Maybe they couldn't move forward because they were concerned or didn't want to, or they want to try other things. In general, that's what I see. Yes, it gets worse over time in that untreated cohort. Now, that doesn't mean there aren't people out there who find some magical thing that works for them. That tends to be, though, less common than more common. Sandra, are muscle relaxers okay for CCI patients? Most CCI patients need as much stability as they can get. So they don't do all that well with classic muscle relaxers or other things that can relax the muscle like Botox. So at the end of the day, they don't really do all that well with muscle relaxers. Now, I want to have one caveat to that. So I would say 2 out of 3 of our CCI patients don't like heavy muscle relaxers or even heavy alcohol or anything that would cause your muscles to be more fluid because they need that spasm to be stable. About 1 in 3 of our CCI patients can use muscle relaxers to kind of dial the muscle tension down a notch, and that is a net benefit. So again, hard to say that all CCI patients react the same way, but I would say about 2 and 3 aren't really getting much benefit, and about 1 in 3 are able to dial that in or thread that needle. Nathan, what symptoms typically need vagus nerve hydrodissection, and can they typically get better with regular EPICL alone? Yeah, so really if there's an autonomic component, Nathan, is where we're looking to do the vagus nerve hydrodissection. Now that's a lot of the patients we see these days, probably at least 7 out of 10. We're then doing a vagus nerve hydrodissection. Now, it's certainly possible that the vagus nerve gets better on its own, and it would be a-okay to talk to the doctor that's at our clinic that's offering you an EPICL and to say, listen, can we just not do the vagus nerve hydrodissection for the first time? I want to see what gets better if we just focus on the other things, and that's certainly fine. Christina, what PT progression do you suggest if headache is your worst symptom? Do you see more success with Lyrica or Cymbalta? Well, to answer that specific question, Lyrica tends to be more effective in chronic pain in general, in my clinical experience, than Cymbalta. And as far as headaches are concerned, we have a lot of patients that take some of the newer monoclonal antibody drugs that are biologics, but that then causes a problem. They tend to be effective because they're heavy-handed anti-inflammatories, so-called CGRP drugs. but they then paint themselves into a corner because they can't get off of those drugs in order to do a regen med procedure, or they have a hard time getting off of those drugs. So I would say that if you could use Lyrica and have it work, that's a pretty good one, because other than maybe messing with some anesthesia, it doesn't really have a huge impact on a regen med procedure. DC suburb, what about severe dizziness and neck movement? I don't know what the question is referring to specifically there, so I'm not sure I can answer that one. Undercover sentinel, can DDD, C5-6 instability cause BTOS, brain fog, vascular symptoms, IGB compression, returning? So you can see thoracic outlet syndrome and 5-6 instability. You generally don't see brain fog. You generally don't see IJV compression with 5-6 instability. Depending on how much instability is there and or how big the disc bulge is, you can get weakness in your legs due to spinal cord compression from a 5-6 issue. So some of those symptoms can map to 5-6. Some of those symptoms usually map to the upper neck. Okay, we're in the last 8 minutes here, so I'm going to pick and choose questions to try to get new people in here. Casey heard a patient try Drovenax for $2,000 a month, said it barely helped the pain. Yeah, that has been my experience so far. Again, that's the hard part about being a patient, right? Is you talk to one person who had one experience, whereas as a doctor, I get to see how it works in 50 people in a serial fashion. So I'd say that Drovenax tends to be pretty effective for pain relief. We've been using it in some post-op pain settings. Dr. Schultz has been using it extensively in some post-op pain settings. It is expensive, right? The drug itself is in that new mode where the pharma company is certainly charging a pretty penny for it. So that would be the real downside of that drug from what I see, given that many pain medications are super cheap. Physical therapy on demand isn't seeing short format. Thank you. Let's see here. Let's see. Annette, if you have minimal pain but lots of neurologic issues from your CCI, have PICL still good outcomes for those patients? And does PICL work for those who have craniosettling as well? So we have a patient population in NET that does very well, that just has neurologic issues but minimal pain, who get the PICL procedure. And then depends on the details behind the cranial settling. We would call that a type 1E instability. So if the type 1E instability is associated with the type 1C instability, those patients do very well. But I'd have to know more to answer that particular question. Casey, who's the guy that drew the drawings you showed earlier? Those are Panjabi, Panjabi. I'd love to be able to pronounce his first name. It's like Morahar or something like that. He is or was now an emeritus. I think he's still alive, but he's very old. Professor of spinal biomechanics at Yale, one of my favorite all-time authors. I've learned an immense amount about spinal biomechanics from him, but those were drawn initially by Panjabi. Obviously, I drew them, but they're off or from Panjabi diagrams. I have severe neck spasm with any near vision activities, including reading and working on the computer or phone. Is this common with CCI? Will respond to PICL? Yeah, so that may be less about vision and more about head position. Now, again, in order to be a PICL candidate, we'd have to type you to, number one, find out if you have craniocervical instability. Number two, if so, what type? If it's a type involving the internal ligaments, then yes. If it's a type involving ligaments that can easily be reached with posterior injections, then you wouldn't need to go down that route. Gene, do you treat many EDS patients, and how is the recovery of connective tissue issues? Yeah, Gene, I would say these days, and I'm just giving you off the top of my head, about 1 in 3 to half of all of the CCI patients we see have EDS. When it comes to the ePICL procedure, there is no difference in outcome between EDS and non-EDS patients. Let's see. Again, I'm kind of picking and choosing some questions here since we're getting towards the end, trying to get new stuff in here. Dr. C, there's lots of people that complain faulty orthodontics can contribute to issues, some cases of creating a crossbite, a nose and sphenoid shift, and cranial torsion. Thoughts on this concept? Listen, I think the TMJ and the upper cervical spine are heavily linked. And is it possible that one can affect the other? I think it is. As far as a crossbite causing craniocervical instability, I don't think that's a thing, but it probably doesn't help. So if you get craniocervical instability, and one of the things that isn't controlled for is the TMJ, then I think you can see patients that don't respond as well. So I have a patient that I recall from a long time ago. He was in the military and ended up getting about 70% relief with ePICLs. And then to get the rest of the way, he had some overall TMJ bite issues that he had to then go get addressed. So the two can interact for sure. Let's see. Kristen, how much overlap between CCI, AAI, and Eagle syndrome symptoms are you able to differentiate between, which could be causing what symptoms? Yeah, so if you've got CCI, AAI, you're going to see a lot of those patients who have Eagles like crossover symptoms. It makes sense to treat the CCI, AAI first, because using something like an ePICL procedure, that's far less invasive than the surgeries needed to treat Eagle syndrome. Then if they still have Eagles type symptoms, they can always get that surgery. If you do it the other way around, then you tend to cause more instability because you're destabilizing the anterior strap mechanism when you do a styloidectomy, for example, and then the CCI becomes harder to treat and you've created a new problem. Let's see here, guys, trying to look through these questions. Chad, can somebody with CCI and spina bifida with the C1 fusing to the skull still benefit from your treatment? So if you've got C1 fused to the skull, then the question would be, what internal ligament system do you have? So that would probably have to be mapped on a very specific upper cervical MRI where we're using a head coil to see what the ligaments look like. But usually what would happen in that circumstance is you would probably still have alar ligaments and a transverse ligament. So it's possible to have injured alar accessory transverse, for example, and have C1, C2 instability. And there's more force on C1, C2, right? Because there isn't any any movement happening at C0, C1. Do you expect the results from PICL to last for many years, or will patients need to come back after wear and tear long term? I've been doing EPICL now for 20 years, and we don't really, I'm sorry, 10 years, I apologize. We don't really have people coming back on a regular basis unless something happens. Now, we do have some patients that have things like structural scoliosis, for example, where we're kind of predicting they're going to need to come back because there's something going on there where there's constant overload happening in the upper cervical spine. Or, for example, we have patients that have adjacent segment disease. So we've got a few patients that regrettably are fused from like C2 to C7, and I'm expecting those people to come back because they can't unfuse their neck. Okay, I think we're almost done here. This will probably be my last question. Efficacy of PRP versus cervical epidural steroid injection for cervical radiculopathy. Platelet-based treatments, in my clinical experience over the last 20 years, are far more effective than steroid-based treatments to treat radiculopathy. Okay, guys, well, that's it for today. I want to thank everyone for all the great questions. Apologize for those questions I wasn't able to get to. And thank you so much for spending the time with me on this Sunday morning. I'll be back here next Sunday morning, I think, doing the same thing. And hopefully we'll have another topic. We may even have a guest. We'll have to see how that goes. So thank you so much, and have a great week. And I'll see you next week. Thank you.